All right. Thank you guys so much for coming, both in person and virtually. I'm very excited to introduce Dr. Karla Washington, who is an associate professor in the Division of Palliative Medicine at Washington University in St. Louis, where she designs, develops, and tests interventions to promote the biopsychosocial, spiritual, and cultural well-being of individuals, families, and communities affected by cancer. So Dr. Washington is a social worker by profession, and she began her academic research career at the University of Louisville, followed by several years at the University of Missouri before transitioning to her current role at WashU. She's also a very dear friend of mine and colleague, and I'm so grateful to be able to share this space with her and do work alongside her and learn from her. So we're going to be hearing about her National Cancer Institute funded work with cancer caregivers, which is part of her broader research focused on promoting family caregiving and well-being. So the floor is yours.
Thank you. Jenny Torts is also a dear friend, and she will not be surprised whenever I can't work a PowerPoint slide, because if you've heard before, you already know my joke, that there's nothing like saying your digital help, which I specifically left out, so maybe the universe will smile on me and allow me to advance the slide without a problem. I most often botch that pretty soon. Well, thank you so much for having me. It's been such a cool time to be here, and I've heard so many different stories, and this has been such a lovely place to spend some time, and also so many people I love who talk favorably about your team and your environment. So I feel really blessed to get to spend some time with you today. I wanted to talk broadly and specifically about family-centered support for family caregivers. If anybody's ever been at this exact point in their grant, I would love to hear if this is a shared experience. I'm halfway through year 4 of a 5-year grant, and it absolutely feels like a lot. We're so close to having findings. We still don't have anything. We've kind of worked through a lot, and so we're just sort of doing it. So some of the work I'll be sharing today, we'll talk briefly about that RO1 study. Is kind of a parent study, but I wanted to share some work Abby and I have been doing. Abby or Dr. Becky?
Abby, please.
Some work that Abby and I have been doing on one of the supplements on the project, which I am also excited to hear. I know we have a lot of community engaged researchers, and this is sort of dipping my toe into that space as well. So I'd love to learn from you when we present this work. I want to start with my family story. And one of the things of working in cancer research that I'm guessing most of you have experienced is that so many families are affected by cancer. So I want to acknowledge that many people, most of us in this room probably, have a story about their family's experience with cancer. But this is somehow 7 years ago when I was pulling pictures from my phone to try to populate this slide. I was back in 2018. So this has actually been quite some time. This is me, and this is my mom, Carolyn, and she loves it that she's in these slides. She didn't just give me permission. My entire family loves. My brother had a condition on his hands once, and this is in his adolescence. He's now almost 60, and he has told so many complete strangers that he's in a medical book. So my family loves to be discussed in rooms like this. So she's perfectly fine with me sharing the experience of her picture, or rather the experience of her cancer. But in 2018, she was diagnosed with breast cancer and had a pretty typical experience through multiple surgeries, radiation, and chemotherapy. We'll talk a little bit. This is her in the chemo room. She was on so many steroids, and she's like a good Southern Baptist woman, so she doesn't drink or do anything. So she's just sort of like virginal in her composition. So she was just high as a kite and had the best time. Chemo days were usually her best days. So this is her feeling pretty excited about. That's my husband shaving her head, which is one of my favorite pictures that I think I'll always cherish. And the reason why I started with this story is we oftentimes as a cancer caregiver researcher, I'm in rooms and someone who goes before me to sort of ask for resources or say, hey, could we screen caregivers for anxiety and depression? It'll take 5 minutes. I'm always in line behind someone who's saying, we don't have enough nurses to give chemo today. We're barely having the ambulatory infusion unit going. And when I think about priorities, it's so hard for me sometimes to articulate a really compelling argument to take resources from a facility that's having a hard time giving chemo that day and saying we need some of these support programs. But I often, perhaps narcissistically or at least egotistically, focus on my own experience when I need to be reminded that this is important and it's worth fighting for. So I run a pretty tight ship. I can be a little rigid and I pay good money. Wednesdays at 9, Jan is my therapist, we're working on it. But I manage my anxiety with structure. And so this is my mom's, these are her pink sheets. If you're old enough to remember in the summary statements, whenever you used to get feedback from the National Institutes of Health, you literally got pink sheets. So I made pink sheets for my mom. And so for chemo number 3, whenever I was with her and I went to all of her chemo treatments, and during chemo 2, I would write her pink sheets out for chemo 3, because her medication regimen, of course, started before chemo day and lasted throughout. I tried to catch all of the brand names and was learning what some of these names even mean because I only knew them by the brand names. I'm not in any way, shape, or form suggesting this is the right thing to do. We were just following doctor's orders. But my mother was at home alone. My father died of lung cancer in 1998. And she was always also an organized woman. The person I turned to for problem solving. She also ran a tight ship and she was just snowed by chemo. You can debate however much you want. I'm happy to read the science about chemo brain. All I'm telling you is this woman who usually was absolutely running her life, mine, and all of my siblings was really struggling. So we really introduced this kind of structure. And of course, it didn't last just one day. It was well over a week. And I also love looking back at this and saying, so it's around this time of year, right? Easter also happened. So we had Easter, and how is she going to be feeling on Easter? And this is after breakfast, and it's in the afternoon, but I'm at chemo. So what do I do in the afternoon? And so I just really like sharing the extent to which I, at least personally, and I think many of our family caregivers felt a part. I felt that I was part of this experience in the cancer center. The other piece, and then I'll stop bragging on how much of tight ship I ran. We also had PRN flow charts because there wasn't just a medication for nausea. Can you lay down? Do you have to go and do something? Are you feeling constipated? But there's a medication you take if you're constipated. Did you already take it? So we really had this whole system in place. And you might be thinking, what an impressive human. We will throw you a parade later, Karla. Thank God you're here, blessing us with your knowledge. I'm sure this went off without a hitch. No, she almost died. So this is her after she's hospitalized for kidney failure. She was wildly dehydrated. A woman ran into her at a car dealership. She was out buying cars. While she was so dehydrated, her kidneys were failing, and she had to learn to basically walk again and have her body function again. It was an incredibly stressful time, and I include this for 2 reasons, one of which is, as you'll hear later, the furniture in a cancer center for somebody who has to be there a long time is really important, and this is my favorite furniture setup. And I also just had all of my work things, because one of the layers for me was that I'm like right on a tenure track. I have this job that I've been socialized to work hard for my entire life. And I sort of was working while I was in the cancer center. I felt like a jerk, right? Because you're supposed to be getting snacks and blankets and making sure everything's okay. And I'm over there answering emails and thinking, you know, one day when my mom dies, am I going to look back on this time and think we should have been holding hands? And it was really just an incredibly distressful time for me. Meanwhile, as I mentioned, she's high as a kite, entertaining everyone with stories. So this is her today. She wants you to know she's fine. She doesn't have any signs or symptoms of illness, and we're still great friends. But I included this image when she was at the car dealership where her friend from church found her and dragged her to the emergency room. She was almost dying. She and I, we bought the same watch one time. She and I owned the same car. We accidentally bought the exact same car. Hers was gray and mine is gold. These aren't our cars. But I included this here because when my mother, she lives about 45 minutes from me, and we often go the same place, so we meet up to carpool. And she chooses the cancer center is where she wants to meet. She has warm feelings. She felt she was well cared for. She enjoyed spending time with me there. And that's where, and it's not necessarily that much closer than a lot of other places. It's that she received cancer treatment in the town where I live. I avoid it. I drive out of my way not to have to see it because that wasn't a safe place for me. I felt really scared. I was really worried about her a lot. I was worried about, should I be working while I'm taking a half a day off to be here for this experience, or is there somewhere else I need to be? And it was just a really distressful time for me, and I don't feel the same way about the experiences she did. So one of the things that I really loved about being at the Cancer Center was they had a puzzle, and we all kind of collectively worked on the jigsaw puzzle, and it's kind of crunchy granola, it's kind of a kumbaya thing. And I really loved it, and I was there one day, and it was a Monday, or it was a Tuesday after a 3-day weekend. My mom had struggled, she needed fluids, I was worried about her to death. And we had called, like, we were good patients, right? We were raised to be polite and pleasant and never complain. So we called at the time and followed the flow chart about how are you supposed to get attention. And no one called us back, and I'm scared to death. So I just show up, right? Which is kind of gutsy for me. I'm kind of proud of the jerk I've become and advocating for her. So we just showed up and sat in there. And a nurse came by that day earlier, prior to the puzzle story. And she just said, oh, you can't show up here. You're supposed to call. And I did. And then she just said, I don't know if you know it, but it was a 3-day weekend. And I'm like, look here. Not only do I know it was a 3-day weekend, I've been counting the hours until you open. So I'm furious. So later that day, I'm working the puzzle. I calmed down. They did see her. They gave her fluids. And the patient service representative came over because she knows I like the puzzle. She was asking me about the puzzle. And I said, oh, no, I love it. I think this is great. And she said, yeah, we really care about being family-centered here. And I'm still like a little bit fuming. And to my credit or to my cowardice, I didn't say anything. But in my head, I'm like, do you think this puzzle makes this a family-centered place? And so that seed was really planted. And years later, so this is the R01. It doesn't have a lot to do with the study I'm mostly going to talk about, except for I wanted to show it. Because this is totally accidental. Jamie and I were talking earlier about the fact that the motivation, in addition to, because we're being recorded, doing good science, making it a better world for everyone, the motivation of most of these supplements is we had a budget cut of 17% in year one, and I didn't know how I was going to keep the grant going. So anytime there was an opportunity to apply for more resources, I was in there. And we accidentally did something I love, and we'll try to emulate this in future grants, in terms of the timing, because we kind of got started. And then my colleague, Dr. Keisha White-McKendy, wrote a diversity supplement that was years 2 and 3. On 3, we added another administrative supplement. And then the project we're going to talk about today was added out of our cancer center. This year, now we're all writing, and all the chickens have come home to roost, or whatever the expression is. Now we have to actually disseminate all this work. But hopefully, knock wood, we're going to do it in enough time to wrap the project up successfully. But one of the things I wanted to talk about today that's really connected to this notion of family-centeredness is the community outreach and engagement grant we got from the Cancer Center. And Abby, like a trooper, agreed to sit through how many hours of online training to learn this method. But we really wanted to engage actual family members of cancer patients in deciding what is family-centered cancer care. So our basic premise is that cancer is a family disease. And really there's broad support. I think you'd be hard-pressed to find anyone in a cancer center who said they don't care about providing family-centered care. It's widely endorsed. People talk about it a lot. But some places it means a puzzle, and other places it means something different. So we wanted to know, what is it exactly? Who gets to decide what it is? So in our literature review and in our establishing a scientific premise for this work, we were able to find a few models for what family-centered care could look like, and they were developed by the people who were really easily able to bring to the table not a lot of racial and ethnic diversity, and a lot of experiences that were missed, and we wanted to do that differently. And then ultimately, we wanted to know what really needs to change to make a cancer center family-centered. So we returned on to group concept mapping, and this is my first, most of this is going to be lessons learned. So if I did it wrong, I can hear that. But just so I know how humble to be, how many people in the room, anybody familiar with group concept mapping? Has anybody done it? A little bit? Yeah, Jamie, some-ish. So with our first, we literally, as I mentioned, we just took the class. So this is the 4th graders teaching the 3rd grade, and we gave it our best. So what I think the model looks like, what the textbooks talk about the model being, is really this 5-step process, and we have 4 shown here. And the first step is really brainstorming. So we pull books together, and we'll talk about in the results section how many and who and what did it look like. But we wanted people to answer or to fill in the blank to complete the sentence. One thing cancer centers can do to support patients' families is blank. And we just turned people loose. We had people do the brainstorming. If anybody hears about this method and is interested, this is our first lesson learned. Because we asked people to do brainstorming as part of our attention matched control for our clinical trial, right? Where there's one group that's getting our intervention, which is problem-solving therapy, and another group has to do something. We have to keep them on the phone, right? Or on Zoom for 45 to 60 minutes. And so we engaged them in brainstorming. As you will soon see rather. So we were kind of prompting them and doing non-directive prompts. And like, oh, what would your cousin do? And right, we're trying to keep this conversation going for 60 minutes. You're not supposed to do that, and here's why. We had thousands of responses, and you're supposed to have 100. So the first lesson learned is when you're brainstorming, allow people to sort of naturally brainstorm, and when they exhaust and kind of peter out, just respect that and move on. We would not include it as part of the attention match control. The other sort of conversation we can have if anybody's interested that I won't spend a lot of time on here is they loved it. And that's really not what you want to have happen in your comparison group for your intervention. So they talked about, we did exit interviews, and they said, oh, this has been one of the most powerful experiences. And I'm like, oh crap. And I really feel heard, and you really wanted my feedback, and I'm making the world better. And I'm like, but you're still depressed, right? Like and then this other thing that we're trying to fix that with or make that look different with. And so those are our experiences with brainstorming, a couple of many lessons learned. The next thing that happens, and I always visualize this in terms of happening in a physical space, it happens online. There's fairly expensive software and support you can purchase. You don't have to in order to facilitate this process. But back before the program entered, we would all, if we were all deciding, let's say we were going to create a place for lunch in this building, and we all had to decide what should it look like. And we would have brainstorming, and I would give you all index cards, and they should have inexpensive food, or they should have healthy foods, or they should deliver to my desk, or we would have all these ideas on index cards. And the sorting step is really, each of us would have our index cards, and we would sort them all into piles based on similarity and dissimilarity. If you're a qualitative researcher, it feels a lot like coding, wouldn't you say? The entire time, like similar things need to be in similar piles. And the piece that really can go wrong here, unfortunately, this is one of few piles we managed not to step in, is the piles really, or the sorts really need to be based on conceptual similarity. So not, I really like this and I really didn't like this, or I think this should be a priority and I don't think this should be a priority. They really needed to be all the transportation things in one pile, all the things about the furniture in the other pile. The next thing we had people do is rate each of the items, which you might now be realizing why it really was a problem that we had over 1,000 items. They had to respond in 2 ways to each item in terms of how important they thought that was. So for example, if someone said, there should be enough parking, enough accessible parking. So then someone would say, how important is that? And then how much was that present in your experience? We actually used verbiage that I don't like, Abby hates, but I don't like it. And then we said how true was this? In order to actually get people to be able to answer it the way we wanted to, we had to say how true. The reason it gets tricky is people would say things like, it is absolutely true that there's a special urgent care at my cancer center for people with cancer. It is absolutely not true. And so like they thought that was true, or to the best of their knowledge. So we really have kind of this problematic language. I get why we did it, but I wish we had spent maybe a little bit more time thinking about language there. And then finally, we had a step where we said, so here are all these ideas, we prioritize them. What should we do? What should we do differently? So we engaged 32 family members in brainstorming. And again, once we got rid of redundancies, we were still at 779. And again, our goal is fewer than 100 responses. So we ultimately eliminated anything to do with the pharmacy. Each of our 3 sites had pharmacy services. Then we took a kind of emergency department, which was pretty painful. There are still some items that we retained, like for example, is there a special ED or is there a special urgent care, but mostly about the cancer center. And then we got rid of inpatient care. These data still exist, and I am ready to move on to another project. So if anybody has students that are pharmacy students or budding hospitalists or someone who's interested in inpatient care, the data still exists. We just didn't use them, and we were able to get that list down to 86. And then magic happens. One of the things that I really liked and am uncomfortable with, although I do have a contingency plan in case you are a statistician and you want to know exactly what statistical tests were run, because we relied so heavily on the program that sort of automates a lot of these processes. There's a point where, so we had people provide us responses and we were ferociously entering them into REDCap. We downloaded them in Excel, or I guess a CSV technically, and uploaded them to the program. So that was pretty straightforward. We didn't have, there were a number of people we wanted to engage for whom just going to the website, which is usually an option, would have been tricky. And again, we really wanted to have diverse voices in terms of our digital literacy in particular. And we wanted to do this sort of attention match control. So we had to approach that very differently. But really, when we get to sorting, one of the advantages of working with this company, with this technology, it's group wisdom. They're fantastic. It's pricey. And there's a lot of things that you need later that aren't necessarily part of the initial package. So there are pros and cons. One of the things that was really nice is it sort of automated a lot of the statistical procedures, which is great. And then whenever you think, oh, I'm going to go see Jenny and Abby and Laura, and I'm going to present this, I'm like, oh, crap, somebody's going to ask me about the statistics. So I have a slide if you want that information. But one of the real drawbacks is in terms of feeling, first of all, comfortable disseminating the information, but also having a lot of confidence in the results. A lot of that kind of happened within the system. And we did have a statistician review them. And I felt really good once we had that piece in place. But there is a little bit of hidden magic that happens here. So when we had everyone individually supported, right, our index cards into piles, and then the magic happened, right? The system generated its hierarchical cluster analysis. Is there anybody in here who's anybody? Okay, we can all ask ChatGPT later. I have a slide if you're interested. But then the magic happens, and the system sort of gives an average sorting. And so the first step in this process, though, is that the program really generates a point map. And so this is very similar in some respects, I think, to social network analysis in terms of the nodes being closer together, the relationship stronger. So each one of these dots represents one of the 86 ways that our family caregivers said cancer centers could support them. And the closer they are together, the more often they were sorted in the same pile. And the farther apart, the less often they were sorted in the same pile. One of the things that was really elegant that I think would be really hard to manually recreate is that the group wisdom program, and they don't pay me, they only take money from me. They're the opposite of pay me. But one of the things that was nice is it created really 13 different solutions. Because one of the things that's really tricky, and you might be looking at this and saying, like, ooh, family support and family education don't feel like totally separate constructs. Or if you're a factor analysis person, you might be saying, those don't feel wildly dissimilar. And it really is because it's constrained by the statistical analyses in terms of what's close or far together. So if there was often the case, it's like, oh, if we can move 27 and 53 over to family education, then that would make sense. More conceptually, and that wasn't an option. However, we did have 13 different constellations of the different sorting. And we ultimately decided that really this 5 cluster solution was what we wanted to stick with. And I have a slide, and it's going to be really difficult to read. I love this work, and the last slide, spoiler alert, is I want to do more of it. So I'm happy to share this with people, especially those who might want to be engaged in this work. But I provided just a single example on this slide. So there's a lot about the physical characteristics of the facility, which I wasn't incredibly surprised by, having reflected on. I was ticked off about the furniture, but there's an entire literature. When we got to the discussion section, I was like, I'm going to rock people's world and say that how you design a cancer center matters. That isn't going to rock anybody. There's a whole field of people that's all they do is think about how to design these environments. But I don't think that we necessarily think about that. Hopefully, when people are building these spaces, those are things they're thinking about. But there's a really rich literature that I'm not familiar with, or that I wasn't familiar with, about really what do healthy, supportive environments look like in healthcare. So one was facility characteristics, and the really key example here is the cancer center is peaceful and calm. Financial assistance is something that came up in our work. There's a group of really phenomenal researchers who did some similar work asking clinicians how to create family-centered cancer care, how to provide family-centered care. And this is one of the ways that our work is really very different, is that a lot of what our families talked about was stuff that happened outside of the cancer center and outside of the clinic. And a lot of the clinicians were focusing a lot on clinical operations, which we'll get to in a second. But this was really something that was key for a lot of our participants. It might have been born out of the fact that we intentionally engaged people who might be in different financial situations than would typically be the case for research participants. And so this example was assistance with travel costs is provided. And in family support, we had resources provided to help family members manage stress. There was a lot on clinical operations. I loved this example. One of the things that's supposed to be true of each item is it's very similar to creating a survey when you don't want a double-barreled item. You don't want two things going on in the same sentence. But in order to get from 7 bazillion to 86, we weren't able to honor that as much as we would like, and that's really on display here. But I really love this one because whenever we had people sort and rate the items, they weren't necessarily the people who had brainstormed them, and we would get a lot of like curse word, yeah, like hell yeah, or something else, a little bit more powerful, or amen. A lot of people saw this and endorsed them. And I think when we think about staffing and all of the ways that it's important, this example really, I think, is powerful in terms of why it matters to families. And so the example I chose here is there's enough nursing staff in the treatment areas. Family members don't feel responsible for monitoring patients. Because whenever we think about in particular treatment areas, do we have chairs with backs? Or is it the little circle stool that you roll around on where you're going to sit for 3 hours, and so maybe you're going to go play puzzles instead because you don't have a chair with a back to sit in there for 3 hours. And so there are a lot of reasons why we might want to have spaces that are welcoming for lots of different family members, but they're in there thinking they're watching their people they care about and love. And then finally, family education, and we'll talk about this quite a bit. One of the limitations of this study and why I think we should do more is because we were supplementing the R01, which was about family caregivers. This was by far the juiciest category. And I'll show you in a minute, we looked at ways that we were doing well, because some things were important, but they were also present, right? I care a lot about this, but you're not going to know the ballpark. But we were really looking for discrepancies. I couldn't care less about this and you're sinking a ton of resources into it, so why, right? Low importance, high presence. But more often than not, the opposite was really what we wanted to target, is what's really important that people aren't experiencing. We saw a lot of that discrepancy in family education. I suspect it reflects reality, but I'm very biased as a caregiving researcher. And so I did want to introduce that here as a limitation. But one example here is instructions for patient care at home are clear and complete. And we left that at family education, but again, because these were caregivers, as you'll see in a moment, a lot of it was about caregiving education. So rating was not a huge waste of time, which is how I used to present this. And then somebody invited me to reframe that. We looked at the scores and cut a midpoint, and anything above a 2.5 on a 1 to 4 point scale was considered important. 100% of there wasn't a single thing in terms of importance. That one of the 2 criteria we asked people to rate, there wasn't a single thing people didn't think was important. So we didn't learn a lot. It wasn't a waste of time. It helps us feel more confident in our results. We should still be very impressed with ourselves. But it felt a little bit like a waste of time when we were going through the Excel spreadsheet, like, oh, sure, check again. But we did have 67 of those 86 responses that received high ratings for, that's poorly worded. They received high ratings for importance, but were low in present, is how that should read. Let me show you a few of those now. And this is really quite hard to read. I'll start with the first one, which is actually when we get to this, so what are we going to do? One of the final steps that we'll talk about in just a second is we engaged a community engagement studio. I know you have those resources here as well. And we just said, here's what we found. What should we do with this? And as a qualitative researcher, to be very, very clear, and it's very important, the community engagement studio people who sent us a whole book about it. It was not research, but I was listening with my researcher ears. Their job was to support our research process, not to be research participants. But one of the things that I heard when they were talking about how do we take recommendations and put them into action was this feeling of being lost. Literally and figuratively. And it reminded me, I have a colleague who's really brilliant, who does navigation work. And she really emphasizes, it's not literal navigation, right? We're helping you navigate the cancer system, hear all these important things. And we had some of those conversations in the community engagement studio. And they're like, well, that's cute. I really mean literal navigation. I can't find anything here. I grew up in this neighborhood. You keep building buildings. I don't know where I am. There's 900 people who are offering to help me coordinate like this system. I can't find where I'm going, and I don't know where I am when I get there. So one of the recommendations that you'll hear about in a second was just maybe we could give people a tour. Maybe we could say radiation oncology is different than radiology, which seems mind-blowing, and here's what the difference is. But if you don't know what those words mean, you might in fact be sitting in the waiting room in point A, and you want to be in point B. So we had a lot of facility characteristics, but in terms of wayfinding, kind of those basics, do I know which exit to turn into? Do I know where to park? Some of those pieces. Financial assistance didn't have a lot of unmet needs. One of the things when we went from the 7 billion to 86 items is in terms of brainstorming, which is actually a step in our intervention, another reason why attention control groups are tricky. We encourage people to just give like preposterous solutions because that oftentimes gets your creative juices flowing. And so people would say things like, they could give everybody $1 million. And I'm like, well, they could, but we're not going to retain that item and ask people to sort it into piles because it's never happening. So there's not a lot there, but a lot of the people we talked with were in fairly financially toxic situations. Then we had a little bit on family support. Do patients and families know how to get free or low-cost mental health services? And this, at least 2 of the 3 sites from which we recruited have pretty robust services that feel to me, as someone who works inside the system, as pretty well advertised. And people were, for whatever reason, for probably many reasons, not aware of those services. Or I was having a discussion, Channing didn't join us. Do we know Channing Tate? I had the most fantastic conversation with. We were talking about, she's a hospice researcher and was talking about that a lot of people don't know how hospice is paid for. So maybe it really is the free and low cost, because those are services that were included, that people who are receiving care from the cancer center could have availed themselves of, but maybe they didn't know that piece. We had a lot on clinical operations. Some of it, whenever we engaged our clinicians in terms of crafting the final document, apparently the idea that you're going to write a note from scratch and not cut and paste from other visit notes is a non-starter. They said, well, actually, we would have cut that out with like giving people $1 million because that's never going to happen, and I'll quit my job before I do that. But whenever people were accessing, we're so lucky to have Jenny, who does work in the portal, which actually is one of the pieces that people commented on not being able to access the portal. But when people are getting into those clinic notes and looking, and they're seeing that this looks like the other one and there's not a lot of specificity, they wanted that to look different. And that may be one that doesn't really move forward. One of the things that I thought about, I'm trained as a social worker, and there were 2, if not 3 things that kind of came through in terms of themes. One was really, when you give me a resource, do you circle back to say, did you get in touch with them? Did they have a waiting list? Did you find it to be helpful? Which I'm sure many of your skilled clinicians do on your team, but I think it would be really easy to forget and start passing out, right, flyers that have bullet points of agencies that might be helpful. The other thing was the warm handoff and the follow-up, I guess, which were separate. Oh, and the third was the proactive provision of support. So not waiting for somebody to say, I'm hurting, or I need this, or I don't have money for bills, just making those available to people without making them ask, without making them or requiring that they ask for it, which isn't something I thought about. I often, whenever I was in clinical practice, would really pride myself on being responsive as someone voices a need, that I really try as hard as I can to meet that. And they were really talking about a much more universal provision of some of that information and support. And then the category that had the most items that were rated high in importance and low in presence or truth was, again, that family education. It was just a whole lot on caregiver education. Patients and families know what palliative care does, could be a little bit of an artifact because we were recruiting out of the palliative care clinic as a palliative care person. I love it that it made it into the final data set, but that was probably, or potentially rather some bias. But things about families are provided with resources about how to be a caregiver. And again, that someone checks in with people in between visits without waiting for a call, which might be another one that's similar for many of us in cancer centers. That might be as feasible as the cut and paste with the note situation, because that would be a lot of phone calls. But we really did try to intentionally create an understanding of family-centered cancer care that was from the family's perspective. And really thinking about sort of an implementation piece, or how do we leverage, how many people love our cancer centers and care about that could be resources that we could train for lay navigation. I think there are ways that we can probably not make notes necessarily easier to write from scratch, but are there ways that we could connect with people outside of the clinic? So we did a community engagement studio, and it was my first community engagement studio, and I was blown away with the first, so you show up and we're all supposed to want everybody's input and feedback because we're grown people, but I just showed up and I was like, oh man, this is going to be, kind of it feels like our whole jobs. We're just like inviting people to critique us, and at some point it's a lot, right? It's like, I've heard enough about myself. I'm telling you about yourself. But so right, this whole experience is that you show up and people kind of try to tell you how to make it better. So as a big girl, I ate a lot, breakfast, we went caffeinated, brought my favorite postdoc in the entire world. So we were all teed up for success. And then we did a little background on the study so that they could give us feedback and said specifically what do you want. And then our job was to sit down and be quiet and listen, which we, I think, did a good job of doing. But there was a moment where there was a little Q&A right after we presented it, so they could ask questions of us. The community engagement studio participants could ask questions of us to get clarity they needed to give us feedback. And the very first question was from a woman, and she just said, well, how many people are in your study who didn't speak English? And I just absolutely, it was like making new combinations of curse words in my head. It's going to be a long day. There's none. She's like, well, do you appreciate the fact that there are 100 people in equity and all this, and you're maybe doing this all wrong? And I was like, yeah. So they had a lot of, and then there was someone, and all these people, and then there's someone they had a double mastectomy while they were living out of their car. Or were those people in the study? I was like, no. So one of the things that we really learned, and a huge takeaway, I'll go over some other key points that I kind of did, again, this thematic analysis of, but one of the things that I heard loud and clear is that the population that we recruited out of the outpatient palliative care clinic, of people who trusted research enough to be a part of our study, who did above and beyond, who actually completed all through the sessions, that we were working with people that had resources that maybe an average patient might not. So as we move this work forward, I think we really need to pay attention to that. So, but the themes that we sort of took away, if we were going to, I think it would be premature. I would love somebody to disagree with me, but I honestly think it's premature to move from these recommendations to clinical practice guidelines or suggestions, just because we haven't heard from a lot of people. But I'm really excited about the foundation that we've built. But one of the things in terms of sort of preliminary ideas is this notion of you are here. And so it was the idea of being literally lost, as we discussed, but also feeling lost, not really knowing. We had someone in the community engagement studio that said, I couldn't have told you at any time what we were doing we were just showing up for things and letting people do stuff, right? I couldn't have told you what we were doing or why. And circling back to my mother, who's a gorgeous woman, my best friend, I love her so much, but I will tell you a story about her. She's not super into classes. And so before we started her treatment, we're at a table like this, and I understand why there's not somebody individually who tells you what chemo is and that you should eat crusty bread or something. These maybe even were later, I was like, those are old videos because you can eat different things now. But I'm looking over this woman, again, who's my idol. She helps me run my whole life. The woman is bored. She's full on digging around in her purse for mints or something. And I'm like, Jesus, you're about to, they're going to pump cancer in your body, and right in there just dishing her out. This is they're going to pump cancer in your body in 5 minutes. You think you might want to get out of your purse? And actually could not have cared. So I'm not suggesting that we're not providing education. It's a delightful woman. She presented this video and set us around a table. But for whatever reason, that's not landing, and I can think of lots of reasons that might be so. So thinking about how we provide that education might be important. So touring, right, helping people with literal wayfinding, but also thinking about how can we provide personalized, ongoing stage or treatment specific education, and that's important. other piece that that really came across that was a little bit more interpretive is that we not only you are here, so where are you, but we want you here. This is the place where we want families to be. So fostering relationships, especially with a point person. And I think many of the times, and we haven't heard from all of the voices, but a lot of the things people were describing, the questions they might have, it wouldn't necessarily need to be an advanced practice practitioner on the other end of the phone. It doesn't need to be a graduate prepared social. It needs to be someone who could point someone in the right direction. Or when I go to the cancer center, I check in with Lawrence. So just a point person that made them feel connected. And communicating that families belong, creating those comfortable, safe spaces for families. I can't gripe enough about the thing that your dentist sits on, the little rolly stool without a back in the cancer center. Clearly communicating what is for family members. This was very interesting, and it's another one that people were kind of like, heck yeah. So in 2 of our 3 sites, there was a culture, I'd be curious to know if it's true here, where people bring in snacks in the chemo room. Or there are warm blankets. There are sort of, I hate to say amenities because it makes it sound like a hotel and people are literally getting chemo, but there are things that are introduced in the environment to make it a more comfortable space. And the families didn't know, like, that's for me, can I, and right, the idea that you're going to be sitting in there with a warm blanket feels like maybe a lot, but maybe one of the bottled waters is for you. But they just really didn't know where did they belong, where didn't they belong, and they wanted to do the right thing. And then providing culturally responsive care. One of the items we cut in getting to the 86 that I felt some sort of way about was many were examples of really specific ways to provide culturally responsive care, and I wanted to retain an example just as we build on this work. At least one of our cancer centers doesn't take cash, and a lot of immigrant communities are cash dependent. So they actually couldn't, even if services were available for purchase, or if they owed a copay, or they didn't have an option that was immediately available for them. So I think one of the concessions that we made that I would love to fold back in as this work moves forward is thinking about those specific examples of culturally responsive care. So you are here, we want you here, but also we see you there. And I think this is really that appreciation that 90% of cancer care doesn't happen in our hospitals. It doesn't happen in our cancer centers. It happens in homes. And prioritizing support for patients and families at home. How do we do that when we have a really hard time having clinical services that are of high standard, high quality in the cancer center? And at what point do we hand off to community partners? What part do we own? But just prioritizing and recognizing that really is where cancer care is happening. Checking in without being contacted first, and then again, proactively providing that caregiver education. So next steps. We already talked about the non-English speakers that I got right out of the gate and knew I was going to learn a lot. But I would love to engage other family members in developing this. One of the questions I have, and I want to start with your questions, but if you have thoughts, I would love to learn from you. I can't decide if maybe family-centered cancer care means different things to different people. And I can't decide, is this a process of having different models for different communities, and so what would that be? Or do we try to create something if we want to change clinical practice? Is it actually not practical to have 7 different ways to be family-centered when we know that we're showing up for meetings where people are saying we don't have enough techs in the hospital today? And does it make sense to try to have something that's reasonably well-defined for a broader community? Adults and other non-caregiving roles. I think we had a lot of people who physically come to the cancer center, and we know most of our families, while most of our patients may have a family member who comes, there are dozens of people and families who never darken the doorway of the cancer center who might still be struggling and benefit from support. And then engaging children and youth, which I think would be so fun. I don't know how to do it, but I know a lot of smart people, and maybe you're those smart people, but I would love to hear from kids and youth about what would be helpful for them. I think harvesting low-hanging fruit maybe makes a lot of sense. I have an idea that even though we are in a challenging moment as a research community, that there are still people and organizations who really care about families and that would really be attracted. And Jamie and I had the privilege of talking about something I don't know how to do, which is how do you connect with organizations that want to do good things with an idea that you think is deserving of support. So I look forward to learning more about that. And then engaging volunteers. We have a ton of volunteers, and I have a colleague I mentioned who really does this work, who are pretty unfulfilled in their role, who feel underutilized. It's really hard to retain them. And might we figure out a way, might we develop a role to really have them providing work that's meaningful to them, that's meaningful to our patients and families? And that's not to suggest they're not already in place. Can we expand that as a potential workforce? And then making family-centered care a sought-after descriptor. I was really naive, and I've told this story once already today. One of our collaborators, the individual who had the diversity supplement, Dr. White McKenday, is a pediatric palliative physician. And I just said, Keisha, this is going to be our future. This is Washington University in St. Louis, is going to be the home of family-centered cancer care. We're going to have a center, and we're going to have an emblem. And every cancer center in the nation is going to want it. And I just said, it's just like, how everybody wants to have an age-friendly emergency department. How everybody wants to be breastfeeding. When did we start caring about breastfeeding? Pretty recently, I would say. And now everybody wants to be like, right, we're breastfeeding friendly. And she just laughed and laughed. And she said, oh, why would anyone want that sticker on their website? I said, people, the Girl Scouts, we have the badges. I don't know, people want them. She said, no. She said, we get more money, or we are accredited by this body, and this gives us extra points. She's like, they're actual metrics. Jamie, remind me, you had a perfect phrasing for this earlier. What a use case scenario? Do you remember?
Yes, I do. Give me 10 minutes.
Okay, so Jamie's gonna think about it. It's basically synonymous with a business argument.
Value proposition.
Value proposition. And so what Keisha was basically telling me is there's no value proposition. People are not just wearing their Girl Scout patch trying to get like the fire building badge. But could we make being family-centered a sought-after description? Does it make sense? Would patients and families actually get better care? Would families have better outcomes? And how can we really carve a path that would allow families to have a better experience in our cancer centers? That is all I had. I would love to hear from you about if and how the work you're doing connects with anything we talked about today. I would love to, I'm very seasoned from my community engagement studio to hear ways that the work can be improved. So what are you doing that deals with families in your cancer center? How does that relate to the work you're doing? Any synergies here? Yes.
Hi, I'm Josh Bassick. I work on the PHSR team and also Dr. Lawrence Marrow. We're doing a couples-based intervention for colorectal cancer.
Yeah.
And so I'm hearing a lot of like threads in this and the work that she's like currently putting out. And the intervention that's being developed, it's like a 4-part intervention, but I definitely think some of this can kind of come forward with us into that work. The family-based kind of element and like making sure the proactive conversation and like asking them instead of like, what are things that you may still feel like you need resources for instead of, what do you feel like you're not being supported with is like a good way to kind of establish that maybe earlier on in the intervention. I would love to, I wish you could have been here, but thank you. And
I'm glad you're here.
Yeah, no.
Well, so when I have a question, let me know if it should be directed to another member of your team, but I would love to hear your thoughts.
Okay.
Tell me about your couples work and thinking about the dyad. One of the things we really struggle with in the caregiving space is, research that suggests, are there circumstances when a dyad makes sense? Or there circumstances when having that separate conversation makes sense? How do you think about that?
We can probably answer this in 2 parts because Caitlin's also done some of the work here.
Hey, Caitlin.
But I'll take the first crack at it.
Yeah.
I would say, especially the partner kind of shouldering more of that emotional load at times where, the patient is focused on their treatment and how can they be, as minimally impactful on the rest of the ongoing day-to-day of the rest of the family unit. But also kind of the partner being as motivated or maybe as overwhelmed and trying to help shoulder some of the like other administrative tasks or family roles that are like being shuffled around.
Yeah.
And then how kind of going forward that may like exacerbate other like challenges happening within the relationship, whether it's intimacy or whether it's communication or like expectations for the future. And so yeah, just a lot to think about, but.
So I want to hear from Caitlin, but before I leave, has anyone seen, and watch it be horrible, and I have not seen this show, but have you seen the ads for Dying for Sex? You mentioned intimacy.
No.
I want somebody in this space, have you seen Caitlin? Yeah?
I haven't seen it, but partly because I don't like to watch content that reminds me of work.
Of work. Well, so if anybody decides, there's a show, Michelle Williams, looking like adorable little pixie cut, presumably based on the ad, has a serious illness, and has just had an unsatisfactory sexual experience or life until this point, but is dying and then somehow goes out on a quest to have great sex before she dies. And so I'm just thinking about, we keep doing all these studies, although it sounds like you're really doing a lot of that work. we have all these studies about all these intimacy challenges and we don't do anything. I'm always really torn whenever it's like, I knew about that before Michelle. Who does she think I've been knowing about this for a long time. But sometimes that really changes the conversation. I'll be curious to see if we have different conversations with people because there's a show. It's hot off the presses. So.
Sometimes that creates permission structure too, because then they're familiar with it, right?
Yeah, that this is something that people think about and it can look different. And based on the ads, it seems like there are some almost extremes. So you could be like, well, I don't need that. I was just kind of looking for this more kind of vanilla option. So I think it might also give people permission to talk about things that they might otherwise see as taboo, because we have some potentially extreme examples on Hulu or Netflix or something. But Caitlin, what would you add in your work?
Yeah, Josh, I think you did a great job summing up that work. We interviewed them as dyads. We analyzed them as dyads. We thought a little bit, we maybe could break it up into challenges that you face as the patient, challenges you face as the partner, the caregiver, and then challenges you face together. But because they were interviewed together, so many of the conversations had such a natural flow. It's like, I also experienced that, but I think it's worse for my partner for this reason. So we ended up analyzing it all together and we delivered the intervention to the couple as well. I think, an interesting thing that came specifically in regards to the intimacy piece is I don't think we heard as much about intimacy as we thought we would, partly because, you're always biased where you're like, I think this is so interesting. Obviously, they're going to want to talk about it. And we just didn't see that. I think maybe part of it was because they're together and, even if it's like something you engage with as a couple, it's not necessarily something that you want to hash out with a third party as a couple.
Yeah.
So I think that we're kind of biasing away from hearing the details, but because it's an area of interest for our investigator, Lauren, I think she'll weave it in kind of without them having to say.
There will be some fines about that.
Yeah, and then so in some other work I do, it's interesting you bring in the family piece. We've actually found that being a single person without a lot of family support facilitates their participation in research, especially when there's a qualitative component, because they want to talk about it.
Yeah.
And I think, but there's nothing that I'm seeing in the ideas that are being presented for family-centered care that I don't think wouldn't also make it a more hospitable place to bring a neighbor or a friend.
Yes.
So I think it's great to just be able to touch on.
So,
this is an intervention that has no real downside in my mind.
Well, I will write that down there. Caitlin at Colorado says there's no downside in them, based on a lot of research. But so it made me think of a couple of things, one of which is we've done some work, it wasn't in the cancer space, so it was ALS. And so one of the things we asked about was intimacy. And then one of the reviewers came back and they're like, we didn't look at a gender effect. And this was, we had exclusively, so we asked about sex and gender separate constructs, we exclusively cisgender sample. And so they said, well, you have to ask. They were actually referencing sex, but they said, we think that there could be an interaction effect. And I was like, I'm so over this work and I want it out and I don't see anything. I was like, why would that matter? And then it was really kind of an uncomfortable, because, we're trying to have these conversations, but also there's this part, it's like, is human resources going to come into that? Really talk about this work? And there's a member of our analyst, there's a member, she was really bashful. He happened to be the only man in the room at the time. And it also felt a little bit like an 80s sitcom, because like, whoa, whoa, whoa. But he's like, so I think we should probably look at an interaction. Like, why would gender matter in terms of the discrepancy between someone's desired and received intimacy? And he's like, well, I think it might. And so how do you have those conversations? And but that might be an instance where separate conversations would be.
I don't think we heard enough to look at anything really specific, but I will say the couple comments that really stood out were your classic bold woman who's been through so much in her hair. She's ready to just talk about how nothing's working like it used to, and her partner's just
The other thing that was so interesting about your comment, just but broader than that specific issue, which apparently is on my mind because I've got to watch TV. But whenever we're in the community engagement studio, someone had said, a lot of your suggestions aren't just for the family, they're for the patient too. Wouldn't it be better for the patient if appointments started and stopped on time? Mm-hmm. And so it was really, and it's sort of a we should have kind of figured this out, that patients are part of the family, not separate from, so it wasn't either or. And, one of the things as a palliative care researcher is, this might even be more about me being a family caregiving researcher. I'll talk to clinicians and they'll say, oh, we care for patients' families by providing really good patient care. And I was like, I'll fight you. We can go outside now. Because that is, and so sometimes when people talk about that, I have a difficult time hearing that, because I think families have unique needs and that there are things you can do in addition to providing good patient care. And sometimes I worry that whenever we say we care for families by providing great patient care, is we're trying to sort of avoid providing that patient support. But the data were really clear. It's like, oh, we actually do care for patient, right? Like whenever we provide good patient care, that is usually, if not almost always, another way that we can really care for families. So that that unit, which again, is sort of, you're like, oh man, it stinks that we had to get to the community engagement studio before we connected the dots. But no, that was really powerful. Your work sounds really interesting.
Yeah.
Wow.
I have something like
Yeah, right.
a little bit different.
Yeah.
I noticed that a lot of the things that you're touching on have to do with like architecture and interior design
Yes.
and what goes into the rooms and how they're structured for families. And I'm wondering how you see that in terms of intervening and making these changes happen. Like, would you communicate with architects, or when there's a renovation happening, when you can communicate on that level? That's a completely different level than, you know, the interpersonal side of it.
So one of the things that I want to say is, I don't think it requires new research. Again, this is an entire field. I don't know the extent to which we do a really good job drawing on that. And I'm sure there are other constraints and considerations that go into designing spaces. But one of the things, which again is a really well-developed construct I just wasn't familiar with, it's an item we lost when we cut out the inpatient care, but they were talking about the remote control for the TV.
Microwaves.
Microwaves came up, people eating, which we love, right? You gotta eat, you gotta eat the restroom, yeah. Blankets came up. One of the specific examples that I really loved that I wanted to retain, because I think you belong here, was a really specific, like, it would have really informed that theme in my mind. But the remote control for the TVs in the bed, it's right on the call button oftentimes, because the patient has to be able to reach it. Like, it makes sense that it would. But so whenever we were doing the brainstorming session, someone said, yeah, but then that tells me that that's not a space for me. Like, that's a space that's designed about what the patient needs. And in my head, I'm like, because, you know, I really struggle. I mentioned, like, whenever I was over there answering emails, and am I supposed to be like massaging someone's feet? Like, I just, many family caregivers have talked about this, and it's certainly something I experienced. You feel like a jerk, like selfish. And I was like, how do you know what the TV, you know what the patient to be able to change the TV? You want us to make a TV for you? And it's kind of, well, no, but do we communicate to people when we have really comfortable furniture in the waiting room, but really bad furniture in the treatment room? Do we say, well, this is where you go. This is where we want you. And so what does it mean? And again, I'm not sure that the TV example is that actionable, because if you put the remote control and it could get lost. But yeah, that example about, are there ways that we can create spaces that convey the message that you belong here, we want you here, this is a space for you, and maybe it's
imagine providing consulting to architects and designers who
Yeah.
are creating these spaces to make sure that they know how to create a patient and family centered space.
Absolutely. And I can imagine, think about how much we struggle in our field to get like our research into clinical spaces, and we literally work in medical schools sometimes. I can imagine that architectural schools and that research, that there might be a big gap, that science to practice divide would be huge. Yeah, Jamie.
Actually, so when I was at U of L, we actually had the opportunity to redesign the entire clinical.
What'd you do?
Cancer center. You should go over and see.
Yeah.
Like it sometime. But we did. We conducted focus groups, and also had professional guidance in there in terms of some of the things that they wanted, and people were genuinely happy that their input was taken into that. But there was no, and the thing I wanted to say off of Laura's comment was that the architects and designers were salivating at the information that we were giving them, you know, because it was not their idea to do focus groups and consult with people who are really into the understanding the context. It was the cancer center's idea to inform them. And once they had it, they were like, oh my God, you know, we did color patterns, we did palettes, we did, you know, space changes, we did decorations, decor, and things, and really everything.
Bought chairs with backs.
Yeah.
Yes.
Yeah, my sister's an interior designer.
Oh, tell us, yeah.
Her master's thesis was on a patient's room in like a stroke recovery unit. And it was like using a lot of technology and to try to get at some of those things, but that's like a master's level thesis, but it kind of makes you think there are a lot of untapped opportunities that probably gets better.
What is the field? It's place-based something. Like there is a whole field that's doing.
There's just wait till the pick comes out. We're gonna cite a bunch of it, but yeah, it's very place. There's an entire journal about their entire journal of other things.
Yeah.
But I do think though that the points are well taken, that how often does the science get, it's very interesting. I wasn't sure that maybe the architects do all know this, but the fact that they were salivating, that they were really responsive to that data.
They
Yeah.
wouldn't have, they simply said they wouldn't have known it themselves and it would have gone different directions.
Yeah.
Without that feedback, so it felt kind of good.
Well, this is very cool. I think, Brian, are we at 1 o'clock? Is that our stop time? I could stay here all day. Thank you so much for having me. I very much appreciate it. And thank you. Anybody is interested or has stuff, I'm Kay Washington. This is gonna change, but it's Washington University St. Louis. It makes no sense. I have that bookstore.
Oh, you're talking to the people at CU Institute. So
Oh, that's right. Angie, I still look. Now it auto populates.
So good to see you.
Wonderful to see you. Talk soon. Thank you.
What is the Cambridge?
Washington.